the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
A very good afternoon to one and all. I welcome you to another session on the webinar series of a paradigm shift towards holistic health in women. Today's topic is incontinence in women. What does the evidence say? We have the honor of having with us as chairperson Dr. Pallavi ma'am. She is HOD and professor of VSPM College of Physiotherapy Community Department. She is also an MUHS PhD guide, and she has numerous publications in international as well as international journal. We are very happy to have you, ma'am. Welcome to the webinar, ma'am. Then it gives me immense pleasure to introduce our speaker of the day, Dr. Pallavi Wakode, ma'am. She is HOD and Associate Professor, Community Department at Sri Kashibai Navle College of Physiotherapy. She has 8 years of experience in the subject, poster making and paper presentation in different conferences. She has various publications in international journal, and she is certified in ANC, PNC, marathon training, and geriatric and industrial health. We welcome you, ma'am, and hope we have a very good session today. Handing over to you, ma'am.
Hello, can you hear me?
Yes, ma'am.
Yeah. So good afternoon. And first of all, I would like to thank Sancheti Institute for giving me this opportunity to have this particular session on the webinar series. And good afternoon, Pallavi ma'am as well. She's here as an expert. So I'll just start with my slide sharing. And in case there is any audio issues, please just immediately put it on the chat box or let me know, okay?
Yes, ma'am, we'll do that.
Yeah, okay. Can everybody see the slides?
Yes, ma'am.
Okay, so do I start?
Yes, ma'am, please.
Okay. So the topic for today is incontinence and what does evidence say. So this particular topic is extremely important when it comes to women's health. And I have tried to incorporate whatever research has been proven by Incontinence Society, International Incontinence Society, and International Urogenital Society or Association. So I have gathered data from all these different sources and articles published by these societies. So objective of this particular session is to understand about the incontinence, to about the types and physiology of incontinence. We'll learn about the assessment and management techniques for incontinence. and to know about the recent advances on incontinence. So I'll begin now. So we all know that urinary incontinence is the complaint of involuntary loss of urine, and this condition occurs in both the sexes, but it's more frequent in women. So now, since this webinar series is about holistic health on women, so we'll be focusing more on the women incontinence than the men's incontinence. Are the slides visible, right? Hello?
Yes, ma'am.
Yeah, okay. So talking about the prevalence of incontinence, in women, the urinary incontinence prevalence is about 10 to 40% about stress urinary incontinence. And in men, it is slightly lesser. It is about 10 to 30%. And there are different types of urinary incontinence, which we're going to see in the further slides. So before starting about the incontinence, we should know the anatomy of the pelvic organs. So yeah, so we all know that the pelvic floor are like hammock muscles. So at the anterior, they are attached to the pubic bone, and at the posterior part, they are attached to the tailbone. And this pelvic floor muscle supports the abdominal organ. And in any case, if the pelvic floor muscle strength goes down, then it's going to have an impact on the abdominal organs. And then we can have various issues related to the pelvic floor dysfunction. Now, like I have already mentioned, these are the pelvic floor muscles which support the bladder, uterus, and the bowel. And if the muscles become relaxed of the pelvic floor muscles, it can give rise to either incontinence or the prolapse of different organ. And this together can cause the incontinence, or incontinence can also be combined with other pelvic floor dysfunctions. So since we're talking about incontinence, we'll quickly just go through the urinary system, with kidneys, ureter, and the bladder, internal sphincter and the external sphincter of the urethra. And again, if there is insufficiency of the internal or the external sphincter, it can lead to incontinence. Now, if you all can see this particular slide, we can see the inhalation and exhalation. So during inhalation, we know that the diaphragm is going down, floor is going down, and the pelvic floor muscles will be relaxed in that case. And when we are exhaling, the diaphragm is going up, and that time the pelvic floor muscles are getting contracted. So we should know about this particular process when we are talking about the management. Nerve supply of bladder, again, we know that we have pelvic nerve, we have hypogastric nerve, and two micturition centers, sacral micturition center and the pontine micturition center, that we will also require when we talk about management. The causes and risk factors of incontinence. So we have pregnancy and childbirth as one of the important cause. If the lady had a lot of home deliveries or normal deliveries, in the later year when the lady is aging or after the menopause, she can start having incontinence. And obesity, alcohol, and constipations are also the other risk factors. Then if the person is suffering from any neurological condition, they can also have incontinence as a symptom. And these are the reversible causes of incontinence, which is given by mnemonic diapers. And these are generally the reversible causes. So we have delirium, infection of the urinary tract, atrophic urethritis, pharmacologic agent, endocrine, restricted mobility, and stool infection. So these are the issues which can be reversible. And if we target these particular issues, even the incontinence can be targeted, and that would be reduced. We'll go to the types of incontinence now. So we have various types of incontinence, stress incontinence. When we talk about stress incontinence, it is about involuntary leakage on sneezing or coughing, any exertional activity. Urge incontinence is again involuntary leakage accompanied by urgency. And we call it as a mixed incontinence when it is the symptoms of stress and urge incontinence are combined. So urgency in urination, and if it is associated with exertional or coughing and sneezing, then it is mixed incontinence. Then functional incontinence is the person is having delay into urination because of any physical disability or any obstacle or problems in communication and thinking. So which is preventing the person into reaching a toilet. So that is functional incontinence. Overflow incontinence because of overfilled bladder, and transient incontinence, which can be reversible again, like we've seen the pneumonic diaper. So that reversible causes can come into transient incontinence, which can happen due to infection or medication. So again, overflow incontinence, stress incontinence, and urge incontinence. So we all know that if the bladder is full, or there is urethral blockage, or the bladder is unable to empty normally, it can give rise to overflow incontinence. For stress incontinence, if there is a lot of intra-abdominal pressure, increase in intra-abdominal pressure, and the pelvic floor muscles are weak, that can give rise to stress incontinence. In urge incontinence, if there is infection or overactivity of the detrusor muscles, that would give rise to urgency or urge incontinence. Then we know that amongst all the types of incontinence, the stress incontinence is the most prevalent. So the prevalence of stress incontinence is about 20 to 45%, and for it's followed by mixed incontinence, which is about 20 to 30%. And one more thing important about urge incontinence, which is given by the evidence, is that the bladder contraction may also be stimulated by different change in body positions. That is, if we change from supine to upright position, it can give rise to urge incontinence, or with any sensory stimulation like running water, hard hand washing, or cold weather, or arriving at the front door. So generally, stress incontinence is more prevalent, but if it is associated with urge incontinence, it is called as mixed incontinence. And most of the times, if incontinence is present and if we evaluate the patient, we can find out that there are other pelvic floor dysfunctions also which are present in an individual. Then in urge incontinence, we can have sensory and motor urgency depending on what issues the person is facing. Due to sympathetic, we can have sensory urgency, and if there are any other issues, then motor urgency can also be there due to contraction of smooth muscles. Then we have extra urethral incontinence. So if we have a fistula between bladder and vagina, like it is seen in this picture, then we can have extra urethral incontinence because the urine will leak from the fistula. Or we can have fistula between the rectum and vagina as well, so which can give rise to incontinence. Then we have reflex incontinence, where the detrusor muscle contracts due to reflex arc, and there is at the brain level there is no sensation to pass the urine, but the stretch impulse from the urothelium will trigger the reflex arc and will make the detrusor muscle contract, and incontinence would take place. Then we have other classifications as nocturnal enuresis, we have giggle incontinence, and we have orgasmic incontinence as well. So if the pelvic floor muscles are weak, or if there's constant or continuous pressure, the person can have different types of incontinence. In male also, the similar type of incontinences are present, but reasons can be different. It would be due to prostate hypertrophy or prostate gland removal, but that is not the focus of our lecture today. Is my voice clear so far?
Yes, ma'am.
Okay. So now we will be going towards the main portion, which is going to be the assessment and the management, because most often we see patients which are of like giving complaints of incontinence. So how to assess the patient and how to do then go about the management is extremely important. So that's going to be the focus. So now, first of all, the symptoms are extremely important. So symptoms and signs are important because I also said that incontinence will also be associated with any other dysfunctions. So when we take the history of the person, or when we evaluate, we need to know whether the person is suffering from any other issues. So we would be asking the individual about the urinary incontinence symptoms. ask or check for pelvic organ prolapse, symptoms of any sexual or anorectal dysfunction, if in the recent past or currently the person is having any lower urinary tract infections, or if the person is having any abdominal or neurological conditions. So having a knowledge of these particular signs and symptoms is extremely important, so that we know on what part we need to focus and how we need to proceed about the assessment. So for the assessment, we have this frequency and volume chart. We can evaluate the individual for consecutively 2 to 3 days, and monitor the input and output of urine for the person. And from this frequency and volume chart, we can probably come to an understanding of how much is the input and how much is the output, and what is the duration of input and output. Is it immediately the patient is urinating, or the patient is having constant episodes of incontinence? So frequency and volume chart or a bladder diary can be an important indicator and can give us a idea. Then pad weight test. Now this is very important. Now International Continence Society had made this particular test as a standardized state, which is called as a pad weight test, and it is 1 hour pad test. They had two pad test, a 1 hour pad test and 24-hour pad test, but they are recommending 1 hour pad test more now. So in this particular test, for 0 to 15 minutes, we ask the individual to drink 500 ml of sodium-free liquid at rest. Then 15 to 45 minutes, we can ask the individual to perform activities including walking, stair climbing of one flight of stairs. And for the next 45 to 60 minutes, we give them activities like standing up from sitting position 10 times, coughing vigorously 10 times, running on the spot for 1 minute, bending to pick up the small object from the floor 5 times, and washing hands in the running water for a minute. So these particular things are done for an hour. And then we can evaluate the person from this 1 hour pad test. So in the analysis, if the weight of the pad is between 1 to 10 grams, then it is known as mild incontinence. If it is between 11 to 50, it is known as moderate incontinence. And if it is more than 50, it's known as severe incontinence. And the similar values are also given for 24 hours pad test. So it is known that a weight gain of less than 1.4 gram during 1 hour test or 4.4 gram for 24-hour test could be a result of sweating or vaginal discharge. So if it is more than that, so because the increase in perspiration may also would change the value, so that also the tendency of the person to sweat or to perspirate will also have to note down. But this particular test of 1 hour pad test would be easy to perform and would give us an idea about the severity of incontinence. Then biofeedback. A biofeedback is an important instrument which can be used for evaluation and for the management as well. So nowadays we get this instrument of intravaginal cone that can be cone, or it can be also called as electrode. So that can be inserted and it can be connected to the phones via Bluetooth, and it would give us an idea of the pelvic floor muscle contraction, of how effectively we are contracting the pelvic floor. And it would also maintain our daily data of the workout. And it can also be connected to the laptop, and it would give us a graph of our pelvic floor muscle contractions, and that can get stored. So we would get to know about our pelvic floor muscle strength and the progress of pelvic floor muscle strength. So that is also one of the important equipment. Then radiological imaging with picture-rating cystography or video cystourography can also be performed. Magnetic resonance imaging can also be performed, but that's not our domain, so we will not focus more on it. Magnetic resonance imaging would also give us an idea about the pelvic floor muscle injury, if there is any, because it will also be important to note about the pelvic floor muscle injury, because Sometimes there might be an history of trauma, in certain cases, natural or unnatural trauma to the pelvic floor muscles. So the MRI is important, and it would give us an important information. Then post-void residual urine test can also be performed with the help of catheterization and ultrasonography. And it's set a PVR, which is a post-void residual volume, which is less than 50 ml, is an adequate bladder emptying. But if residual volume is more than 200 ml, it is inadequate emptying. Then abdominal leak pressure is important, which is also done by urodynamic study. So abdominal leak pressure is also called as cuff leak pressure or Valsalva leak pressure, and more than 150 centimeter of water is suggestive of incontinence. So it is also a diagnostic test. Then cystography. So in this particular thing, we can monitor the pressure of the various muscles during filling and then voiding phase. The uroflowmetry. So now we know that this is an uroflowmeter, and the person can be asked to urinate, and it would give us a graph again of the urine flow. Now this is our domain, which is pelvic floor assessment. So we'll be focusing more on the pelvic floor assessment. Now, when we talk about pelvic floor assessment, we can do this particular assessment in two formats: external and examination, and an internal examination. So we always perform external examination first, and then we go for internal examination. So first of all, when we perform pelvic floor muscle assessment, the person's comfort is extremely important. We need to make the patient comfortable. We need to, educate them about why this particular assessment is important and how we are going to go about it. And checking all these sterile precautions is important. So during the external examination, we need to put the patient in crook-lying position and take all the sanitary precautions, and then check whether there are any color changes in the skin. So if there are any infections, any abnormal lumps which are present, if the individual is having any urinary leakage, or if any pelvic organ prolapse can be seen, or if there are any other signs of vaginitis, or if there are any other structural changes. So all these things can be viewed in an external examination, and we can note them down, and then we can move for internal examination. So in internal examination, again, taking all the precautions is extremely important. Taking the consent of the patient is important. And when we perform an internal examination, we can sweep in the circular motion to check for muscle symmetry. We can insert the fingers and check if there are any scars which are present in the perineal area because of episiotomy or because of any perineal tear. Then during the same time, we can ask the patient to cough and see if there is any prolapse or if there is any incontinence episode. And then we can check the strength of the pelvic floor muscles. So the strength of the pelvic floor muscle is checked by this perfector method that we will see now. So it is PERFECTR, which method is used for a pelvic floor muscle assessment. So P is power. So it is grade of muscle strength according to modified Oxford grading. E is endurance. So endurance is time in seconds during which the patient can tighten pelvic floor muscle strength when it is up to 50%. Then R is repetition, number of pelvic floor muscle contractions patient can perform, allowing 4 seconds rest in between. F is fast, which is number of fast pelvic floor muscle contractions the patient can perform, and contracting the muscle as strongly as possible. So PERF, so these are the quantitative techniques, and E is elevation. So does the posterior vaginal wall lift during pelvic floor muscle contractions? So that we need to answer in yes or no. Then co-contraction. So do the lower abdominal muscles contract during pelvic floor muscle contractions? So again, we need to answer in yes or no. Then timing, synchronous involuntary contraction of pelvic floor muscles on cuffing. and R is relax. So ability to relax between pelvic floor muscles. So when we talk about pelvic floor muscles, we generally talk about contractions, but relaxation is equally, relaxation of pelvic floor muscle is equally important when we talk about the assessment of pelvic floor muscles. So again, I would repeat, it is PERFECTR. So P is power, E is endurance, R is repetition, F is fast, E is elevation, C is contraction, co-contraction, T is timing, and R is relax. So this is the first power, which is graded by modified Oxford grading classification. So grade 0 is no contraction. Grade 1 is very weak contraction. Grade 2 is again weak contraction, increase in tension without lift or squeeze. Grade 3 is moderate contraction with some degree of lift and squeeze. Grade 4 is good contraction, producing elevation with some resistance. And grade 5 is strong contraction and strong resistance. So this is how the example of pelvic floor assessment would look like with P perfected element. So we just need to note the time. So evaluation would be done for a minute, and during that particular minute, how many times the person was able to contract the pelvic floor muscle, how effective they were, we would be documenting that. So in power, we would be documenting the strength of pelvic floor muscle, and in ECT, so elevation contraction, we would be documenting. These are the pelvic floor dermatomes. So if there are any changes in the external examination when we perform, when we do the sensation testing, if there are any deficits, we can just draw this particular on the patient's evaluation sheet or the format, and we'll come to know whether in any particular dermatome is affected, so that the treatment techniques can also be, focused more on these things. Then this is the ring. So again, in the evaluation format or a sheet, we can have this particular ring drawn, and then probably we can document of if any scar is present in the pelvic floor assessment, if there is any prolapse which is present. So we have urethra, we have vagina and anus. So if there is any scar or any other dysfunction which is present, we can just draw and mention it there. Then we'll talk about the questionnaire for incontinence. So this is the questionnaire for female urinary incontinence diagnosis. Now, this is again used as a diagnostic criteria for incontinence. So in this particular questionnaire, the first three questions are about the stress score, and the other three questions are about the urge score. So if we have the scores in this particular categories, we can come to know whether the person is having stress or the urge incontinence. So it is a short, valid and responsive instrument, and it can use as a diagnostic tool to determine the urinary incontinence type. Then revised urinary incontinence scale. This can be used to give us the severity of incontinence. So in this scale, if the score is less than 9, we can have say that it is the person is mild incontinence. If it is between 10 to 12, moderate incontinence, and if it is more than 10, severe incontinence. So we have questions like urine leakage related to feeling of urgency, and we have a Likert scale here, not at all, light, moderately, and greatly. So we can mark the questions, and we can have the scoring, and we can grade the question. Is my voice clear?
Yes, ma'am, it is.
Okay. So then next we have is incontinence quality of life scale. So that can be used to give us an idea about the quality of life of an individual. We have incontinence impact scale, which can also be used. So these are the different types of outcome measures that can be used to give us an idea about the patient's abilities and the activities that patient is involved into, and some scales are for severity of incontinence.